So now I'm going to introduce Cliff. I think Cliff is, how to introduce him. He's actually the first PhD graduate from the Department of Psychiatry, and he's going to defend his thesis very soon. Cliff has been with us for a number of years, did fantastic work in terms of many aspects, but he focused on the cannabis use and also ADHD kind of comorbidity and cannabis use. And he's going to talk today about cannabis and psychosis. Is there an aspect of psychotic illness that promotes cannabis use? Cliff.
Thanks for having me. I'm going to present some of the work that I did as part of my PhD project, which I had the great privilege and pleasure of carrying out at pepp-montreal. And it's a great honor to participate in today's celebration of our accomplishments at the clinic. So as we heard a lot about already today, substance use and cannabis use is harmful in the context of first episode psychosis, and I feel that there hasn't been great progress in terms of treating these the cannabis use in the people that don't stop on their own following entry into first episode treatment. And a question why these people are particularly refractory to treatment might be, is there something about the illness that makes them have a harder time stopping their substance use or cannabis use in particular? So in terms of understanding the comorbidity of substance use and psychotic illness, I guess you could make three models. A toxicity model suggesting substance use is primary, causing psychopathology, which in turn causes psychopathology. And there's a lot of evidence, of course, in the case of cannabis causing psychotic symptoms. Self-medication model suggesting that people are trying to relieve symptoms of their psychotic illness by using substances of abuse. And also finally the common factor model that suggests neither disorder causes the other necessarily, but there might be a third factor which confers risk of developing both a psychotic illness and a substance use disorder. So none of these models are mutually exclusive. There may be some truth in all of them, but we're mostly concerned with the last one for this presentation. And we're focusing on cannabis, not because we think it is the only substance of abuse that may apply in terms of our ideas, but because there's so much use of this substance that it's very convenient and it's very relevant in this first episode population. So what strategy can we employ to try to identify a possible common factor in cannabis use and psychosis that might underlie both disorders? So first thing we can do is ask patients why they're using cannabis. A lot of people have done that type of research, and that's our first study that we can find. So then to find a common factor, we need a characteristic that is more highly present in patients with psychosis than controls, and that is also associated with problematic cannabis use. So based on existing evidence, there's good candidate common factors. Two of them we've looked at. One will be part of this presentation will be reward processing deficits. And also we did a study that Dr. Joubert referred to on childhood attention problems and ADHD, which we found there's evidence for that as a possible common factor. So these studies were carried out with patients from the PEP clinic. Some wasn't strictly first episode. Some of these patients had been in treatment a bit longer, as some of them were more after 3 years of treatment, about a handful of those, but most of them were within the first 3 years. We were also recruited control subjects through online classified ads. So the first study is just looking at self-reported reasons for substance use, and there's been a lot of research on this question, and I felt like it might be worth revisiting because might be some people who are skeptical of the notion that there's aspects of psychotic illness that could be involved in people's cannabis use. And I think some of that skepticism has come through this type of research. And in order to reopen the door on the possibility that elements of psychotic illness could encourage cannabis use. I thought it'd be interesting to revisit this question. And there's some limitations to this type of research, and I don't think it should be conclusive in its own. I think it's been useful, but first of all, when you ask people for their self-reported reasons, you're assuming they have a great deal of insight into their cannabis use, and as clinicians, we're also often talking about the limitations of psychotic patients' insight into their primary disorder. So there might also carry forward that they have limitations in the insight of their substance use disorder. And also, some of the existing studies have had methodological limitations, and we thought we could try to improve on some of those by using empirical methods to categorize reasons for use. Sometimes people come up with in excess of 20 reasons, examining which reasons are related to the intensity of use, not just how often people endorse using for a certain reason, but whether that's related to heavy use or not, comparing patients and controls, and looking at a specific substance. So we thought this might be worth re-examining also, because there's been a good validation study of a new instrument looking at reasons for substance use in schizophrenia. So this instrument has had a factor analysis performed on it, so that they've created 3 subscales. So all the different reasons can be categorized into 3 categories: coping with distress, social enhancement or intoxication, and individual enhancement. We made it just apply specifically to cannabis. So we administered this instrument to 60 psychosis patients and 73 controls who had some basic lifetime experience with cannabis. And everyone also simultaneously self-reported how much cannabis they've been using in the past 6 months. So we found what many other studies had found when we simply looked at the level of endorsement of different reasons for using marijuana, that it was almost the exact same list of reasons for the patients and the controls that came out in the top 10 out of 38 reasons. The top 10 was basically the same in the 2 groups, just shuffled around a bit. But we thought that that might be interesting to go a step further, because there's some reasons that would be highly endorsed in any group for using cannabis, because perhaps they require minimal self-reflection, they're non-threatening, and sometimes even a euphemism. Like a couple subjects said, "Of course I get high to get high." It's kind of the same thing to them. So the next step was to look at the subscales, the different types of reasons, and to see which ones are associated with heavy use. So we did see quite a striking difference between the patients and controls, that controls were using for the more the controls endorsed using for this type, all 3 types of reasons, the more heavy they were using. But for patients, their use was related to social enhancement and intoxication, but not coping with distress. That the people that were using for coping with distress were not using more heavily. So it might be stretching the data a bit, but because that social enhancement intoxication factor had so many different reasons within it, I thought it'd be interesting to see which reasons were most highly related to heavy use, which specific reasons in patients. And as you can see, most of the reasons have to do with trying to enhance a positive state of mind, similar to the patient we saw earlier, Tina, who was a heavy user, who seemed to be using to feel good, to get pleasure. And not in this study anyway, we found that reasons related to coping with distress were highly related to heavy use in controls, but not in patients. So we found evidence that if you look in more detail at reasons for use, you can in fact see some differences between patients and controls. And this provided further evidence for our interest in looking at reward processing as a factor in comorbid cannabis use and psychosis. So we wanted to see if response to natural rewards and drug-associated rewards, we wanted to examine that in cannabis in dual diagnosis patients that have cannabis use and psychosis. And we wanted to see whether lower response to natural rewards would predict how much cannabis these people are using. So our main outcome measure, this was a measure of physiological response to different images And our main outcome measure was an ERP measure, which kind of gives an immediate response, brain response to visual stimulus. And this measure has been associated with motivated attention to salient stimuli and is related to memory encoding. So it's the more you react to the images, the more you respond on this measure, the more you're paying attention to them or processing them. So there's been evidence in schizophrenia that patients have a deficit in their response to pleasant images as measured with this LPP component of the ERP response. And also that people who have a low response to pleasant images who are substance users, tend to use more substances, have a trouble time stopping use of substances. So we thought that the patients would show a blunted response to pleasant images, and that we also looked at cannabis images, and we thought that perhaps they would have a preserved response to cannabis images, and that the blunted response to pleasant images would predict greater subsequent cannabis use. So this is it's a very simple experiment. Everybody just passively watches a slideshow of different types of images, neutral ones, pleasant ones, unpleasant ones, and cannabis-related images. And I've censored some of these images so that no one in the audience has too great of a response. And so after looking at this figure, just shows a typical ERP response to the different types of images below. And then if we quantify that response to the different types of images, we see that the two groups of patients here, or the two groups of control, have a significantly higher response than the two groups of patients to the pleasant images. But if you look at just the cannabis users, the cannabis using patients and controls respond at exactly the same level to the cannabis images. So that confirmed our idea on that patients would have a deficit. And furthermore, when we look at if it's related to how much marijuana these people report using, we found that people that responded less to the pleasant images were using more cannabis 1 month after the experiment here. In terms of the patient group, in terms of the control group, it was not statistically significant, but the same direction. If we combine them in a regression, controlling also for the amount of cannabis they'd been exposed to prior to the experiment, we found it was still predicting their future cannabis use. So we saw that blunted motivated attention towards pleasant images was related to both psychotic illness and frequency of cannabis use, and motivation attention to cannabis images was preserved in the cannabis using patients. So perhaps one risk of with the increasing evidence that cannabis can cause psychotic symptoms and so forth, there perhaps is a risk of blaming patients for their illness, or of blaming the comorbid patients, that if only they weren't using drugs, they wouldn't have had a psychosis or come to the clinic. But it might be a nuance in that relationship that it's important to remember that some of these people might have a particularly hard time stopping using substances, and that some element of the illness might potentially be getting in the way. And that could potentially also be an explanation why some of the standard treatments for substance use have not been as effective in psychotic illness. And if we were in some way to improve reward processing in psychotic disorders, obviously that would have a lot of positive implications, but one might be better substance use outcomes. So I'd like to thank everybody who was involved in this work, Ashok Malam, Martin Lepage, my two supervisors, Mathieu Baudard, who helped a lot with the ERP work, and Rita Joubert, who was very influential in this work as well. And everyone at PEP, the research and clinical staff who had a huge role to play, and of course all the patients who were participated in the studies. Thank you.
Any questions to Cliff? Okay, thanks Cliff.